We're starting a bit late today. So today's topic will be on a Strobe equity checklist, which will be focusing on an article presenting, which is highlighting issues of health equity. And there is a revision of Strobe checklist with an extension, which is the Strobe equity checklist. So Dr. Anuka will be presenting an article to see whether it fulfills the checklist of this new extended checklist. Without any delay, I'll hand over to Dr. Anuka for the presentation. Thank you.
Good morning. Today we'll be looking at the extension, Strobe Equity Extension. So Strobe is a checklist. So first it is a reporting checklist for observation study, whichever type it is, case control, cohort or cross-section study. This is an extension to that, looking at the equity aspects. So few basic concepts before that. So equity is different from equality. Equality is giving everyone the same thing. That may not benefit them. But equity is actually addressing or looking at taking into account their inequalities and giving things which will be fair and useful for them. So that is difference between equity and equality. What is health equity? Now, health equity is achieved when everybody has equal and fair opportunity to attain their own optimal health. Now, health equity relevant observation studies are the studies that look at unfair or unjust differences that may not apply to differences that are avoidable or unavoidable. For example, if you look at breast cancer, it might be more in women of older age with certain families, but that is just biological. We know that with age, the risk of incidence of cancer increases. There is genetic component to that. But if we look at treatment of breast cancer in certain groups who are not able to afford it, that will be looking at the health equity aspect of that. So these are the things that are differences which are unavoidable. Now, how do we recognize equity? So there are some framework. This is a progress plus framework. So this looks at place of residence, the race, the occupation, gender, religion, education, the status, the social network, and plus looks at 4 other things. So this is one framework which you can use to realize if there is component of inequity. So this is one of the studies which looked at different inequities which can arise. Other framework is equals guide multiple. So that also is similar thing. Which addresses issues of race, education, area they come from, the language they speak, their economic aspect, the gender aspect, and other physical disability. So these are few frameworks which give an idea to inequity which can exist. Now we know Strobe is for observation study. This is from the Equator Network. So Strobe statement is a guideline for reporting observation study. Now, this is a Strobe checklist for a cross-section study. We'll be looking at one cross-section study. So this is how the checklist looks for cross-section study. And I think we have covered this before in previous sessions. Today, we'll be looking at the Strobe equity extension of that. So what is Strobe equity extension? So this is designed to guide the reporting of health equity data and considerations in observation study, any topic that looks to investigate differences in health that are avoidable and considered unjust. So this one is applicable for all cohort, case control and cross-sectional studies. Now this complements the Strobe. This equity aspect can also be used according to along with the record guidelines. Now this is focusing on transparent reporting. This is not to inform study design or implementation. This is just to how to report. So this is how it looks at. So this is Strobe item. This is a recommendation, which is there in the previous checklist. And this is the extension part of it. So 0.1, 1.1. So we will be looking at this checklist today. So there are 22 items with some items which are corresponding to the extension part of it. And we will be focusing on that today. So if you look at the healthcare scenario in India, this is one of the, this is from the National Health Profile. We know that ischemic heart disease is one of the very common and a serious health problem in India. And this is from a Lancet study which looked at the incidence among many non-communicable disease, and among that the cardiovascular disease is the biggest problem for us now. Now we know that for a STEMI, the gold standard is revascularization. Whichever way, either you do a PCI or you do a thrombolysis, but revascularization is the gold standard for STEMI. But we look at the healthcare access by state, there is disparity in the access to health. So there are some areas which have more access to health, some areas which are less. Now, in spite of having access, is there an inequity to access the existing healthcare facility? Now, to answer that, we'll go through a story. Suppose there's a 58-year-old farmer in a place called Villipuram in Tamil Nadu. 8 a.m. while working, he has chest pain. By the time the family recognizes and takes him to the nearest primary health center, it's 8:30. There, the doctor suspects a STEMI, but there's no ECG to report. So he's referred to the nearest district hospital, so, which is 40 kilometers away. So he reaches by 10:30. So this is a non-PCI capable hospital. So ECG there shows STEMI. He can be thrombolized, but there's no stock for streptokinase. So he's referred to a referral center, which closest for there is Chennai. So now they have two options: either go to a private center, arrange ambulance, go to private center, which has some economic impact to that. They have to arrange money. So the arranging the ambulance and the money takes around 2 hours. They also have an option to use the card, but they have to go to the centers which will use the card. So they take 2 hours to arrange the ambulance, and by the time they reach Chennai, 3 p.m. So it's 7 hours after the onset. The angio shows a LAD obstruction, stenting is done, and post PCI, the echo shows a reduced ejection fraction of 35%. So he is at a risk for heart failure, and with long-term implication, and also long-term implication to his returning to the activity of daily living. So we see that here there are multiple issues: delay in recognition, unavailability of infrastructure, problems in referral. Has come to a center, but there are no stocks, medications available. And the final, by the time he gets access to healthcare, there is a delay. So today we'll be looking at this study, which looks at disparity by race and ethnicity in percutaneous coronary intervention. So this is a study which was published on September 18th in JAMA. And since this has an equity aspect to it, we'll be using this Strobe equity extension checklist to go to see how it is reported. So just a brief about the study, what the study is. So this study is a cross-sectional study. The aim is to evaluate at what stage of STEMI care process does disparity happen. Now, disparity in PCI, which is a standard, the way they said PCI is based on the receipt, PCI receipt. The population they chose was all people, all adult patients more than 80 years with a STEMI, presenting to all emergency departments in one single state in Florida. Exposure, they looked at race and ethnicity. So they divided into 3 groups: non-Hispanic, non-Hispanic Black, Hispanic, and non-Hispanic White. So this is a cross-section study. There is no comparator arm as such, but for the analysis, they have compared non-Hispanic Black and Hispanic with non-Hispanic White presented to the same hospital. They postulated that there might be 4 problems in the STEMI care process. So they are looking at these 4 outcomes: initial presentation to a PCI capable hospital, receipt of PCI if presented to a PCI capable hospital. Now, if they are presented to a non-PCI capable hospital, what is the transfer likelihood? And if referred, receipt of PCI in the non-PCI capable after they are referred. So this is a cross-section study. They used all statewide hospital and ED discharge database. So this is the checklist we'll be using today. The first part of the checklist is title and abstract. Does the study design tell you that there is a component of equity in it? So this is the title: disparities by race and ethnicity. And we can make out that there is an equity component to this. And this is abstract. So they have given what type of study it is. They have given the objective. They have told, mentioned that it's a cross-section study. They have mentioned the setting. They mentioned the exposure they are looking at, which they think is causing disparity. And they have given the outcome results. And they have also told conclusion, what is a disparity or inequity they are addressing. Second part is background and rationale and what are the objectives. Have they stated the objectives well? So they start by how MI is a problem. They have also said that the issue in MI is within a window period, they have to reach to the hospital center. So they have said there are some problems in certain groups reaching there. So they have said there are problems in both reaching the hospital and receiving the care. And this is what they're trying to address. Now they are saying what implication it can come to. And this is where they describe the rationale or relevance of inequity or whatever the disparity they are trying to look at. The next part of the study is a method, study design. So you present early on what are the key elements. So they have told it's a cross-section study, and they have told already they are looking at 4 processes where they think the disparities can happen. Now the equity component is to report where experiences of inequities were addressed. So here the first part is where the people who were involved in inequities were involved. So the public involvement or patient involvement is not explicitly mentioned here. Did the research team had individuals who lived with experience of inequities? That part is also not mentioned. So they have said that they have used a diverse academic and clinical researchers, but they have not mentioned, actually they have not involved individuals who have lived with the experience of inequities. Next part is on setting. The setting, so this, they looked at a single center study. So that was to focus on because different state will have different policies that might interfere with the data. So they took a single center study, Florida. They took all the statewide database discharge receipts. So they took from both hospital and emergency discharges. Now the hospital data, they have a healthcare cost and utilization project. Now this has receipt for so they have federal hospital, which is similar to a government hospital, and the non-federal hospital payment data is actually in this database. So they have taken all the patients who present to both emergency and state emergency department, or in all the emergency departments in Florida. Sample sizes was all the ED visits which has happened between January 2011 to 2021. Now, was there a tailored recruitment? But they have taken probably not applicable here because they have taken a statewide census of all the patients who presented with STEMI. Participants, so this is a cross-section study to give the eligibility criteria and the sources and method of selection. So they have said that they have taken all statewide data. They have looked at patients with STEMI. The inequity part is where inequity is part of it considered. So they knew that people who are referred, some group might be transferred to another hospital. So they have taken transfers. So they have included transfers to other hospital, which include also including the inequity part, which might be happening here. And they have grouped all participants by the race. So they had 3 groups. They had non-Hispanic Black, Hispanic, and others or white. Now variables, define the outcome and exposure and variable, and define the sources. So the independent data variable they used was the combined race and ethnicity variable. The outcome variables were if all the patients who came to a PC, all the patients who went through one of this process. So process 1 is they came to a PCI capable hospital. Process 2 is they got PCI based on the receipt. Process 3 is they came to hospital which is not PCI and transferred. Process 4 is they got a PCI after being transferred. So these are the 4 processes they looked at. And they got the data they have taken all the data. They have taken the Medicaid and the Medicare data. They have taken the payer data, self-payment data, and they've taken, they have the variants they have taken adjusted for age, based on the time of ED visit, comorbidities, distance from hospital, year, everything. And so this is taken from the database. So these are the ICD procedure codes they have chosen to find the data. Now, describe any potential to address potential sources of bias. So we know that this is a cross-section study taken from a database. There are chances of potential bias. So they have mentioned around 10, 11 methods they have done to reduce the bias. So they have talked about stratification. They have talked about patients might be referred based on their ethnicity. So they have included that. They have said which is defined very well, which is a PCI capable hospital. They have looked at the ICD classification so that they do not miss the data. They have excluded patients. They have included patients in the main analysis, the patients who went DAMA, so that they don't have a sample bias. So, and they have excluded diabetes because a lot of them might go for a CABG. So they have talked about the ways they have measures they have taken to reduce bias. They've also talked because there might be clinician bias and implicit bias, the subconscious bias based on that. So to put that, they have ensured that there is standardizing hospital protocols. The next part is study size and the variable. So this sample size, they have taken all the sample. So they had taken all the ED visits and they have told the people whom they have dropped out. So finally they had 1,39,629 patients who were included in this study. And these are the 4 processes which we talked about. So each process they have analyzed and they have given what is the sample they have chosen for that. And they looked at 3 things. They looked at overall, they have looked at Medicare, which is their equivalent of insurance, and hospital effects. Statistical analysis. So they have actually described in detail the analysis they have done. They have talked about, they have done a logistic regression. They have accounted for clustering. They have done a secondary analysis. And then they have also looked at, included the differences and adjusted that in the analysis. Now the results. So report the number of individuals at each stage. So this they have given a number in each stage. So this is the final sample size. And after logistic regression, which have excluded also, they have commented on. And here described why they were excluded, what was a non-responsive, that part also they have given in detail, what were non-accounted for. Next part is give the descriptive data, and the extension part is report characteristics of patients with missing data and follow up with inequities. So they had divided into Hispanic, non-Hispanic black, non-Hispanic white, other or missing, and they're given overall. If you look at the generalized, they had ED patients who were either admitted, transferred, died, or lost to follow up. Around 60% of them actually received PCR in initial hospital. They were around 60 years, male predominant, which is similar, which would expect in our population also. They had included what was the payer type. They had included the comorbidities, admission time, because based on the time they present to admission, based on the shift, the transfer rate might change. They have also commented on what type of hospital. Is it a public or a non-profit? The bed size of the hospital, urban or not urban. The last part is if it's a cross-section study, report the number of outcome events. So they had taken 1,39,629 patients with STEMI from between 2011 to 2021. Now coming to the main results. So to give both unadjusted estimates and the analysis. So they had looked at 4 things. First is difference in the probability of patients with STEMI who present to a PCI capable hospital. So they have compared, so they have looked at Hispanic and non-Hispanic black. They have compared it with whites. So they have looked at 2 groups. They have looked at overall patients, all the patients, and they have looked at Medicare. So there was a previous study which looked at only Medicare. So the overall self-payment, that part was not captured. So here they have looked at both Medicare and overall. If you look at, if 0 is where the whites are, so non-Hispanic black is around 2% less who are presenting compared to the white, and Hispanic is around 3% less. So they are both are actually less compared to a white population, non-Hispanic white. Now they have also given the odds ratio. So they have compared with white as a reference. So here the odds ratio for Hispanic was around 0.7 and for black around 0.8. They have also looked based on what type of payer they were, self, Medicaid or Medicare or private, and they have compared it to the private. Now this is the second process. Once you come to a PCI capable hospital, do you have a receipt for a PCI intervention done? So this looked at all the hospitals If you look at all the hospital, non-Hispanic black seems to be less, around 10% less. In public hospital, Hispanic seems to be equal to white, but non-Hispanic black seems to be less. In a non-profit hospital also similar we see, and for profit hospital also non-Hispanic black seems to be represented less. The third part in the process they thought where the problem might arise is probability of transfer when they come to a non-PCI capable hospital. Here we see if this is 0 compared to that, both are actually less. If you look at overall within hospital transfer, both are less. But however, for the Medicare, it seems to be equal to the whites. The last is once they are transferred, probability of getting a PCI receipt. So here also, if you look at, if you take 0 as a baseline and compared with that, non-Hispanic blacks seem to be doing worse than Hispanic, who are almost comparable to white. So this were their primary results. The last part of the Strobe item is the discussion. So the key results, limitation, interpretation. So they have told, they have talked about the key results. They have said that in all the 4 process, they found that black and Hispanic patients were less likely to receive at each step, and they've given the percentage. They have also compared with a previous study, which looked at only a Medicare aspect, payer aspect. And they have looked at the limitation, but they have looked at the limitation of the study, not as such limitation of the equities as such. And they have concluded that 2 areas of focus could be standardizing hospital protocols at PCI capable hospital and improving transfer. And between this, they have also given policies to reduce disparity based on their study. The last part of the checklist is to report on funding, which they have reported, and the funders had no role in the design or the conduct of the study. So this study has come later after the checklist was, the checklist had come later after the study was published. But apart from few aspects, they seem to be aligned well with the equity extension also. Now coming to our scenario, we know that cardiovascular problem is a huge issue here, but we also have disparity based on the state. There is a statewide distribution, the problem in that. Looks like Delhi, Kerala and Tamil Nadu are more. Is it because of more reporting or is it just because of more incidents? We are not very sure, but there is a difference in the prevalence. And access to healthcare. So this data is from Kerala. So this is a map of Kerala. Green are the hospital within half an hour. Yellow is a hospital which takes more than half an hour but less than 1 hour. Blue is the access to only thrombolysis, and red is no access to perfusion. So you can see that some of the area with no access to perfusion is actually quite a lot in significant amount in Kerala. Now what is the scenario in Tamil Nadu where we are? So these are the ST elevation STEMI clusters in the state of Tamil Nadu. So now in order to address this problem, there is a STEMI initiative for by the Tamil Nadu. So this is actually was put forward as a STEMI, Tamil Nadu STEMI program. So this is actually the protocol for the Tamil STEMI program. Dr. Thomas Alexander was one of the person in the group. This started in 2012. What does this have? So they have divided in the whole region of Tamil Nadu hospitals into 4 groups. Hub is Class A, Class B hospital. Class A hospital is a hospital which can do PCI, which is open 24 hours. Class B is a hospital with PCI facility, but 8 to 5. Now, Class D is other hospitals which has facility for thrombolysis. Class C is a peripheral center which is no facility for thrombolysis. So they're divided into A, B, C, and D. And there is a STEMI myocardial infarction kit which has an ECG. And this ECG can be directly sent via teleconsultation to a cardiologist in the center of the hub in Chennai. So how does it work? So this is a hub and spoke model. So hubs are the Class A and Class B hospital. So hub 1, H1 is a hospital with a PCI capable hospital, which is open 24 hours. H2 is a PCI capable hospital open for limited hours, 9 a.m. to 5 p.m. Now spokes are the peripheral hospital. Now S1 is a hospital which is more than 30 minutes, half an hour from the primary hub, and thrombolysis capable hospital. Spoke 2. S2 is a hospital where ECG can be done. This is within 30 minutes from a hub. So this is how it look like. So the PCI will happen in the hub. Spoke 1 would be a hospital where you can do a thrombolysis and then refer. Spoke 2 is hospital within 30 minutes from a hub where you can directly refer to a hub. So this is a hub and spoke model. And once you come to this network, ambulance will pick you up and transfer to a hub or to a S1 spoke where thrombolysis can be done, but not to S2 where there's only ECG done. So this, once you go to the network, you will be directly transferred to the nearest, either the hub or the thrombolysis area center nearby. Now, so if you have an onset of symptom, there are two pathways which can go. Either you can directly go to the hub and get a PCI, or you go to a spoke where emergency ECG is done, send via teleconsultation to a center cardiologist who would diagnose a STEMI. And once a STEMI is diagnosed, either you go to a nearest spoke S2 where thrombolysis can be done, and then followed by a pharmacoinvasive PCI. Or if you fail thrombolysis, you'll be immediately taken to for a rescue PCI. Or if it is spoke is within 30 minutes, you would be directly sent to a primary PCI center hub. So these are the spokes and these are the hub. So this is the spoke and hub model which is there implemented in Tamil Nadu. Now, this was a study done later, 2021, where they talked about the experience in that and it's given some scope for improvement. So, Tamil Nadu is one of the states which has implemented this. This is similar in Goa, which has started in December 28, and this is their model. So, what is the implication? Now, the story which we saw will change little bit like this. So, suppose a 58-year-old man, Villipuram, farmer from Villipuram, 8 a.m. if he has a chest pain, family will recognize the importance. If they recognize chest pain, they can call 108 ambulance, which is a free ambulance, part of the network. Ambulance supposed to arrive within 15 minutes. Ambulance has a facility for a portable ECG, and where trained people the ECG will be sent to a center in Chennai and STEMI will be diagnosed. STEMI is diagnosed via telemedicine by a cardiologist, and they are sent to the STEMI hub and spoke network. So if nearest would be a district hospital, 25 kilometer. To start now, patient will reach by 9:15, where streptokinase will be, thrombolysis will be done. Repeat ECG showing partial resolution, referred for a rescue PCI. The same 108 ambulance will take to a hub PCI's capable center in Chennai. And via the transfer, the supportive treatment and other supportive treatment and the APT statins will be given. 12 p.m. reached, angio showing proximal LED, stenting done. But since it is done within the window period, myocardial can be salvaged and there is a possible of not having any heart failure. So this is probably a good working model currently in Tamil Nadu, which has probably addressed a little bit of inequity to, especially access to healthcare to a lower socioeconomic and out of reach group of patients.